Hello, my name is Joe Pinon, and I'm a student in the Healthcare Simulation course at the Naval Postgraduate School. I would like to propose a method of learning that will enable nursing staff of surgical companies to develop and foster the clinical skills required to be mission ready. The reason I'm proposing this method of learning is that most of the skills required for a surgical company to be ready are skills that are not performed very frequently. Maintaining clinical competency in skills that aren't performed frequently is a very difficult thing to do. Surgical companies will conduct field exercises to rehearse these skills using scenario and simulation-based training. The training teams will use algorithms and checklists to evaluate the training and validate their competency. Relying on algorithms and checklists minimizes critical thinking and may compromise the ability to solve problems. Another shortfall of these algorithms is that they are a linear type of evaluation, which gives a done or not done type of evaluation and doesn't truly evaluate the skills being demonstrated. This limits the students' decisions and their ability to problem solve or to correct mistakes. I'd like to talk a little bit about checklists and linear types of performance evaluation. Unfortunately, the medical battalions don't have a standardized type of checklist. However, the Emergency Nurses Association, or ENA, and the American Heart Association, or AHA, both have standardized checklists for the courses that they offer. For ENA's trauma nurse course, I have pulled out one skill step, which is assessing the airway. And before I go into the scenario, I'll explain what these double asterisk items are. ENA's policy is that the students must identify these items in this order and perform interventions in this order if needed. So what I've pulled out is the airway assessment, which is step 7 for this particular scenario. So the student is supposed to ask if the tongue is obstructed, if there's any loose or missing teeth, is there any foreign objects, any blood, vomitus, or secretions, edema, snurgling or snoring, or any bony deformity. When the student asks those questions, the instructor replies, there is no tongue obstruction, no loose or missing teeth, no foreign objects, no blood or secretions, no edema. However, snoring is heard when the jaw thrust is released. This information is a trigger to the student that this patient has a compromised airway and something needs to be done. So for this scenario, the ENA wants for the student to place an oropharyngeal airway. So after the student assesses the airway and determines that the airway is compromised, they need to apply an OPA. After they put the OPA, then they reassess the airway, and the instructor says no snoring is heard, the airway is now patent. And then the student says, I think I want to I want to intubate the patient, I want a definitive airway. So then the instructor replies, the team is preparing. So what I mentioned earlier about not these types of checklists not allowing students to critically think or problem solve, this is just one example of of this checklist kind of limiting the student to just put it in the OPA. Let's say that the student, after getting this information about snoring being heard when the jaw thrust is released, decides immediately that they want to intubate the patient. Well, according to this checklist, the student would have failed this skills demonstration because they skipped this double asterisk item, which was to apply the OPA. Now, is it wrong to go right to intubation? I don't believe so, and I don't think anyone would argue that intubating someone instead of placing an OPA is the wrong thing to do if the airway is compromised. So that's just one example of these checklists often limiting the students' choices and critical thinking. The next checklist I want to talk about is a checklist that the AHA uses for their basic life support course. And this checklist is really just the instructor's observation of the student's performance of skills. And what the instructor will do after the student performs a skill is just put a check in the box if it's been done correctly. If the student does not perform the skill correctly, then the instructor will not put a check in the box, and the student will have failed the return demonstration. So I'm going to skip down to skill step 4, which is give high quality CPR. So in order for the student to successfully or give high quality CPR, the hand placement has to be correct. It has to be an adequate rate, adequate depth. They have to allow for complete recoil of the chest, and they have to minimize interruptions. So when all of those are done correctly, then the check in the box will go here for each cycle, and they're supposed to do 5 cycles correctly. So I think you can see how they are not going to get a lot of valuable feedback from this checklist when they have these different, variables of things that need to be done right. If one thing is done wrong, then they don't pass that cycle. It isn't necessarily the same thing that's going to be done wrong every time, but you wouldn't really know unless you have a very astute instructor that is paying close attention and can tell you, hey, for this particular cycle, your hand placement was off. Cycle 2, your hand placement was good, but you didn't allow complete recoil of the chest. And even with that, the student might not retain all that information. So this is an example of these checklists not really giving a lot of valuable feedback to the student in terms of their skills performance. The learning model that I'm proposing is actually a hybrid of two validated learning models. One of them is experiential learning, or Kolb's theory. And what Kolb said was that we learn by experiencing things, and after we experience them, we kind of reflect about it and start thinking about ways that we could have done it better. And then we do it again, and we see if those ideas that we had actually were better or not. And if they were or were not better, then you reflect again after you go through that experience. So you can see that that really is basically what we do in simulation training. Is we have these experiences, usually in a scenario kind of situation, and then we reflect and think about it. Or ideally, that's what we'll do during a simulation. Now, when we are limiting ourselves to these checklists and algorithms, we might not be having all the reflection that we need to have on our experience, because we're not really trying to figure out how to solve the problem or treat the patient. We're really trying to memorize those checklists and algorithms and give the right answers so that we can successfully complete the checklist. Decision problem-based learning, or DPBL, is the other learning theory that makes up the learning model that I'm proposing. In DPBL, a virtual patient is used to present information to a student. The student then discusses its information with the instructor and then makes a decision about the best course of action or treatment for the patient. For example, a student will receive information about the patient's respiratory status, like the breathing rate, the depth, and any breath sounds that might be heard. The student will then have a discussion with the instructor about this information and start talking about possible treatment options. For example, if a student was to hear snoring respirations or shallow respirations, they'll have a discussion with the instructor and say, hey, I'm worried about this person's airway. I'm thinking about putting on a non-rebreather mask, or I'm thinking about putting on an OPA, or I'm thinking about intubating. And after this discussion with the instructor, they'll make a decision either to put on a non-rebreather mask, put on an OPA, or intubate. Whatever they decide, they'll then go down that course. The model I am proposing I have termed convergent learning, and as I mentioned, it's a hybrid of experiential learning and decision problem-based learning, but real-time will also be incorporated into the training scenarios. To help conceptualize this, I've placed an XYZ model in the slide, where the x-axis represents real-time. So once the scenario starts, time will be recorded until the end of the scenario. The y-axis represents biofeedback, patient's condition, and any patient history that is available. The z-axis are the decisions and interventions that the student makes based strictly on the information that they receive. Once they receive this information, they'll make a decision, and that'll impact directly the patient's condition. There's no discussion with instructors about what the best course of action is. It'll be strictly based on the patient's presentation. I've included this diagram to help visualize the workflow of virtual patient in convergent learning. So for this particular scenario, the student needs to manage the patient's compromised airway. So does the student identify that the patient is not breathing? If they do identify the patient is not breathing, do they decide to do positive pressure ventilation? If they do decide to do positive pressure ventilation, is the technique good? If the technique is good, then the patient's O2 sat goes to 96%. If the technique is not good, for example, the mask is not sealed or there's a leak in the bag or some other reason that the technique would not be good. After 3 minutes of bagging with bad technique, the O2 sat will drop to 82%. The student must then be aware of this drop or recognize this drop and again provide positive pressure ventilation until they have good technique and they get the O2 sat to 96%. Alternatively, they can make decisions that'll result in the patient going into VFib or have cardiac arrest. At the end of this scenario, the student's performance will be evaluated. They receive a detailed performance summary that will include a computer-generated report of their performance, actions which improve the patient's survivability, actions that may have been detrimental to the patient's survivability, and recommendations from the subject matter expert and the training team. In conclusion, I hypothesized that the convergent learning model will help nurses develop and maintain the skills required to make a surgical company mission ready. However, this model needs to be validated through research and data collection. In the next slide, I've included references of readings that help me develop the convergent learning model. Thank you.